So, dear Chairman, dear colleagues, good afternoon. I would like to thank Professors Karamasis and Professor Philippatos for the kind invitation, and I would like to say that I feel very honored to be among experts in the field. So, what do the guidelines say about this very interesting clinical scenario, as we have seen today? And to begin with, I would like to say that I feel very lucky to be having been trained in a clinic that has the expertise of Professor Dimitriadis and the availability to get familiar with these methods. So, just to remind you, the basic endotypes of ANOCA and INOCA patients. We have the abnormal vasodilatation, or else we can say that this is the endotype of microvascular dysfunction, which includes endothelial dysfunction and impaired vasodilatation. And then we have the abnormal vasoconstriction, which includes epicardial vasospastic angina and microvascular vasospastic angina. And of course, a combination of endotypes. So I really like this illustration from the guidelines. And what does this illustration say? It says that when we see patients referred for interventional coronary angiogram combined with functional testing to see the microcirculation, we can see that up to 70% of women and up to 50% of men referred for this modality do not have obstructive coronary artery disease, but do have some signs of ischemia or microvascular dysfunction. And focusing on these patients, the patients of INOCA and ANOCA, a percentage of up to 80% has proven endothelial dysfunction, a 60% can have vasospasm after the acetylcholine testing, and up to 50% can have abnormal vasodilatation, and just the 25% of these patients had documented ischemia in non-invasive testing. And why do we care for these patients? We care because they have recurrent angina, they have recurrent hospitalizations, they have repeat coronary angiograms, as we seen in the previous case, and they also have poor quality of life and significant incidence of MACEs, especially in the cases of vasospasm. So, let's see the guidelines. As Dr. Milasinovic clearly highlighted, we have a class 1 indication to perform invasive coronary functional testing in cases of persistent symptoms despite optimal medical treatment in cases of suspected ANOCA and INOCA. So we have to up-titrate, add drugs, and if symptoms continue, then we perform invasive coronary functional testing. And just as a reminder, we can see that when we have the abnormal vasodilatation, this might be proven either to be an endothelium-independent endotype with measures of after adenosine testing with low CFR and high IMR, or it can be an endothelium-dependent endotype. This is still considered abnormal vasodilatation in the low dose of acetylcholine. And the abnormal vasoconstriction is proven either epicardial or microvascular when we inject high doses of acetylcholine, as it was previously shown. And now, focusing on the diagnostic procedure for vasospastic angina, guidelines say with class 1 recommendation, of course, the classic ECG recording, uric angina, which can show ST elevation, but as we saw, there are cases that ECG could be normal. And of course, in patients with suspected vasospastic angina and repetitive episodes of pain, associated, it says here, with ST changes that prove to resolve with nitrates or calcium antagonists, invasive functional coronary testing is still suggested with class 1 indication to prove that this is the diagnosis and to exclude the severity of concomitant atherosclerotic disease, which is a common scenario. And about the management, Well, according to guidelines, there are class 2A indications that medical therapy after these tests that is targeted and based according to the endotype that we diagnose should be considered because it can improve symptoms and quality of life, it says here. And generally, for the management of endothelial dysfunction, ACE inhibitors and statins should be considered. But when we focus on microvascular angina associated with, as we said, impaired vasodilatation, further antianginal medication should be considered, as I will show you in a moment. And now for the treatment of isolated angina, this is for the first time an indication, class 1, that calcium channel blockers are recommended to control symptoms, but also to prevent ischemia with potentially fatal complications. Not only symptoms and quality of life for this clinical scenario, and nitrates also should be considered to prevent recurrent episodes. And to conclude, I will show you this very clear illustration, which shows that in this clinical scenario of patients with ANOCA and INOCA phenotypes, we should still focus on lifestyle changes. We should still focus and give priority to the management of the common risk factors. They share the same risk factors with the obstructive coronary artery disease. And now, according to the guidelines, the targeted therapy should include cardioprotective drugs, as ACE inhibitors and statins have proven to be, but also when we have a clear diagnosis of the endotype, further targeted treatment could be beneficial. And as we can see in the endotypes of abnormal vasodilatation, this includes all the antianginal drugs that we have, starting with beta blockers, CCBs, ranolazine, trimetazidine, and ivabradine. And for the endotypes of abnormal vasoconstriction, the epicardial disease needs CCBs, nitrates, and even nicorandil can be used. It could be even used in this scenario, could be my suggestion if nitrates do not help. And microvascular disease, as Dr. Milasinovic said, we could combine CCB with a second CCB and or nitrates. So thank you very much for your attention.
Thank you very much. I think in the interest of time, we'll move on. Thank you for this very nice overview. Just maybe a final word from me. I think the most important, we've opened many subjects, but I think the most important message is what you showed from the guidelines, that we now have a class 1 indication for this therapy. What it means, translated into ordinary language, I think, is that we need to have a justification why we did not do it when it's indicated very often. And this is, I think, a big change. In the past, it was optional. Now we really have to ask ourselves why we did not perform invasive physiology testing in patients without obstructive epicardial disease. And that, I think, is a big change and a move into a direction where we will be performing these tests more and more. That being said, I would like to ask Simone, as the next speaker, who is really an expert in this field,